Olá, meu nome é Vitor Arantes, estamos aqui na quarta temporada do Sobedcast. Hoje eu tenho o privilégio de entrevistar o professor Peter Draganov, professor associado da Universidade de Flórida, em Gainesville. Nós vamos discutir hoje sobre o tratamento endoscópico do divertículo de Zenker. So, Peter, welcome to Sobedcast. Thank you for joining us today. So I'd like to discuss with you the Zenker diverticular management from the endoscopic perspectives. Could you show us how are the major advances in this field for endoscopic therapy?
Thank you, Vitor. I'm glad to be here. I appreciate the kind invitation. Zenker diverticulum is relatively uncommon, but when it develops, it tends to create patients significant problems, mostly related with dysphagia. And over the years, there have been various approaches that have been implemented to treat Zenkers. Traditionally, surgery was the main modality, and that was an open surgery. The problem with surgery is not only it's invasive, but actually the success rate is relatively low because the diverticulum is posterior. It's right against the spine, and access for the surgeons was not easy. Therefore, once transoral modalities became available, they quickly became the primary modalities to treat Zenker's diverticulum. Of the transoral modalities, there is two main ones. One is a transoral stapling of the diverticulum with a rigid stapler. And the second one is using flexible endoscopy to incise the diverticulum. A common question that patients ask is whether we are removing the diverticulum, but that is not the case. Typically, we just open the diverticulum and create a connection in between the diverticular cavity and the esophageal lumen. And that is always combined with myotomy of the cricopharyngeal muscle. A good way to think about that is if you have two rooms with a wall between them, you knock off the wall in between the two rooms and now you have one room. But those are currently the two preferred modalities: rigid stapling and flexible endoscopy.
Okay. Let's talk about the flexible endoscopy, that is our major field of interest. So regarding flexible endoscopy, what options does the endoscopist have to open this septum that separate the diverticulum and the esophageal lumen?
We have doing septotomy or incising of the septum for many years now, and initially the procedure started with doing the incision using ERCP needle knife. And that procedure was proven to be safe and effective. Nevertheless, the recurrence rate in the literature has been reported in the range of 15 to 20%. So clearly there was a room for improvement. One of the main concerns with the traditional septotomy is that you want to completely incise the septum, but if you cut too much, you have a perforation, which can result in mediastinitis, which, needless to say, is a very serious complication. So we usually have been cutting almost to the bottom of the diverticulum, but not all the way to the bottom of the diverticulum. And that is the proposed mechanism of recurrence. Because you don't completely excise the septum, some patients will recur. As time progressed and we got more versatile with third space endoscopy techniques borrowed from ESD and from POEM, we now have a better armamentarium of devices and techniques to tackle this task. And that is on multiple levels. For one, we have a variety of incision knives. We have needle type of knives, we have insulated tip knives, and we also have a scissor types of knives. And physicians, endoscopists use those based on personal preference. No one knife has been proven to be better than other, but certainly having a choice to fit somebody endoscopic skills and preferences is a great thing. The second thing that was borrowed from the third space endoscopy world is the availability of hemostatic devices, specifically coagulating forceps. Luckily, the posterior aspect of the hypopharynx is not highly vascular. We rarely get a bleeding, but when you do, now we have the devices to handle it easily, which was not the case in the past. Finally, we now have learned to use tunneling techniques that were initially developed for treatment of achalasia, the POEM procedure, which now is referred as EPOEM, E standing for esophagus. But now that tunneling method has been translated to the Zenker's diverticulum, and it is referred in the literature as Z-POEM. In addition to that, we have a G-POEM to treat gastroparesis incision of the pylorus, D-POEM to treat diverticula, particularly in the esophagus, D standing for diverticulum, and so forth and so on.
Nice. Let's talk first from the flexible endoscopy, septotomy. Which kind of knife do you prefer? How is your approach if you're using this technique to incise the diverticulum?
Indeed, the original technique of septotomy was described using a needle type of knife, but importantly, a needle type of knife that was not specifically dedicated to third space endoscopy. It was borrowed from the ERCP armamentarium. And the problem with that was that the control of the needle, how much needle extends beyond the catheter, was quite difficult. Sometimes when you open the knife, you have a lot of needle extending from the knife, sometimes very little. And even worse, as you are doing the cutting, the length of the needle extending from the catheter can change. It can become longer, and that was a potential safety issue. The current knife that we use has a predetermined length, and when fully extended, you know exactly how much knife is out there. So a lot of people prefer the needle type of knife just because of familiarity. I personally prefer the scissors type of knife just because it is more controlled. The beauty of the scissors knife is that once you grab with the scissors the tissue, if you're not happy of where you have positioned the scissors, you don't have to cut. You can release and then re-grab again. So in my opinion, you have more control. And that is particularly important when you're working with fellows and trainees in general, because there is less of the freehand technique that you have to use with the needle type of knives. In addition, some endoscopists use insulated tip or IT type of knives, and that was mostly early in our learning curve. Now my subjective experience is that most people will use a needle type of knife or scissors type of knife, sometimes both in the same procedure, but less commonly the insulated tip knife.
Okay. And do you still see a place for that diverticulotum that you mount into the septum to expose it in case of doing a flexible septotomy?
I believe you're referring to the tunneling technique or the Z-POEM technique.
The one from Cook.
I understand. Yes. So the device was never approved in the United States. I have a limited experience with it, mostly because of doing live courses in Europe. That said, by speaking with colleagues, if you position the device correctly, it does help. But the problem was positioning it correctly. And I have seen personally that actually during that positioning, causing a significant trauma in the area, so making the things worse. My personal impression is that even in countries where that device is available, it's rarely used. Because with flexible endoscopy, you can work very up close and personal with the diverticulum, and the use of distal attachment or a cap stabilizes the operative field. But you're correct, it's a very narrow and tight operative field, but the cap typically is adequate, and that's what is always needed, and no need for any additional devices.
I see. So when Z-Poem came, first the impression we had it was too complicated, too complex. So talking about Z-Poem, the tunneling method, how we can make it easier to approach doing this technique of tunneling for the septotomy in the diverticulum?
Vitor, you're absolutely correct. The original Z-Poem technique included mucosal incision in the hypopharynx and then tunneling for some distance, 3 or 4 centimeters, until you reach the septum of the diverticulum, then tunneling on both sides of the muscle septum, and then finally incising the muscle septum. That certainly made the procedure quite lengthy. You can do a traditional septotomy with a needle knife typically within 10, maximum 15 minutes. With the Z-Poem, we were easily going over an hour. The biggest challenge, though, was closure of the mucosal incision. The hypopharynx is a very tight space, and standard clips tended to be very difficult to position in a way to close a linear incision. So it was a major challenge. We quickly realized that and pivoted and improved the technique by doing the initial mucosal incision right on top of the septum. So you first inject with some saline typically, then you do a transverse incision over the top of the septum, and you immediately start to tunnel. For some time, and still some endoscopists use tunneling on both sides of the muscle, and then they cut the muscular septum. But variation of the technique rapidly emerged where you tunnel only on one side, and then you cut the muscle without tunneling on the other side, which of course related and translated to a faster procedure. That concept was taken even a step further, that people did not tunnel at all. They just were cutting selectively the muscle and preserving the mucosa on both sides of the muscle by just visualizing the submucosa. And actually that technique was originally described with esophageal poem, where you do the myotomy without any prior tunneling. In a way, you tunnel as you go, but in the Zenker's area, it works much better. And the biggest advantage of the poem conceptually is that you can incise the muscle all the way to the very bottom of the septum. Typically with standard septotomy, you have to stop just a little bit before the bottom of the diverticulum, because otherwise you have a perforation with potentially quite serious sequelae. So that has been the evolution. And the last step that now I have seen that people do is after they cut the muscular septum during the Z-Poem, after that they will trim the mucosal incision. And then the question comes, why do it in layers? Why you just don't cut mucosa, muscle, mucosa all at the same time? And that's what I typically do. In a way, it's standard septotomy, the only variation of the technique that I utilize in my own practice is when I am approaching the bottom of the diverticulum, only then I start cutting the muscle only. And that leaves a small amount of mucosa, which will help me then to close the incision with clips. Enough mucosa for me to approximate it easily with standard through the scope clips.
Oh, that's an interesting alteration of the initial technique. So you use the scissor type knife, cut initially the mucosa, then you will find the muscle.
Yes.
We'll cut the muscle until you think is the bottom of the muscle, but you preserve the mucosal layer. I mean, when you're getting closer to the bottom of the muscle. Is
Yes.
that what you are?
That is correct. But the initial zip-worm technique, you preserve the mucosa in its entirety, which leaves still a septum in between the diverticulum and the esophagus. It's only mucosa septum, but may cause a problem in the long term and contribute to recurrence. So people started trimming more and more and more mucosa. So my current technique is to cut the mucosa almost to the bottom of the diverticulum, but actually I extend the muscle incision beyond the bottom. So I have completely taken care of the muscle layer, and I leave a small amount of mucosa at the bottom of the diverticulum, enough to allow me to clip it with through the scope clips.
Oh, very nice. So, quick questions, Peter. Do you use antibiotics, general anesthesia, inpatient, outpatient? How is the practical approach?
Very good. So, Vitor, keep in mind that Zenker's is a relatively uncommon disease. And in addition to that, everybody technique is a little bit different. So the caveat is that we don't have a high quality, extensive experience. Most of our experience that is out there in the literature consists of case series. So with that in mind, in our institution, we do not give antibiotics. And we do not admit patients afterwards because we do close the mucosal incision. In some institutions, closure of the mucosal incision is not done, and in that case, they admit the patient. But I know of colleagues that even if they don't close, they still don't admit the patient. The main argument to admitting if you close with clips is quite reliable, but probably you can better control the patient diet, because we do tell the patients to stay on clear liquids for 2 days and then move to soft diet. But there is always the question of compliance. People usually have fasted for a day before the procedure, they're hungry, and may not necessarily follow the instructions that we give them. But in our institution, no antibiotics, no admission, yes on general anesthesia. The reason is that we have easily availability of general anesthesia in our unit. Actually, all of our cases, even a rectal ultrasound, are done with anesthesia assistance, not general anesthesia, but propofol type of sedation. And because we have that capability, we use it. In the literature, certainly people have described the safety of doing septotomy and zip-worm without general anesthesia, and that is okay. The risk of aspiration is relatively small, and as I already mentioned, significant bleeding is quite uncommon for Zenker's diverticulum. Different thing with Killian-Jamieson diverticulum, which is a lateral diverticulum. It's even less common than Zenker's. There you can have a big vessels and you can bleed. And if you have a significant bleeding in unprotected airway, that's obviously a reason for concern.
Yeah. You know, Peter, I would like to share with you and our colleagues nice news. Very soon in GIE, we will publish, we have been accepted our paper about a meta-analysis that we made comparing flexible endoscope septotomy and tunneling methods for the Zenker diverticulum. These studies that we made showed the clinical response, the adverse events were no different, but the long-term response was better for the tunneling technique as compared to the flexible endoscope septotomy. So very soon I will invite you and our colleagues here to read this manuscript.
Congratulations. I'm glad that you have embarked on this project because it's a very important one. The tunneling technique potential theoretical advantages was that you have less recurrence. That's the main reason to do it. And now, thanks to you, we have some objective evidence to support that theoretical consideration. Thank you very much.
Yes. So thank you. I think that was a very good Sobedcast. We covered the entire characteristics and the advance on the Zenker diverticulo management. I would like, on behalf of Sobed, to thank you very much for participating in our Sobedcast. Thank you.
My pleasure, Vitor. Thank you for having me.
Thank you.